Good morning, good afternoon, good evening, wherever you are in the world. Bienvenido, welcome to Pharmacy Skills. We are looking at the respiratory chapter in the BNF, specifically devices for drug delivery. What are some advantages for drug delivery directly to the lungs through inhalation? Well, for starters, it is direct. And the journey is straightforward, kind of like catching a direct flight. A lot of the time when we give drugs orally, we tend to lose some along the way as they get to their destination, especially if they're given orally, like I said, because inhalation is direct. It means we can afford to give smaller doses because we don't have to compensate for drug loss along the way. Does that make sense? And lastly, the advantage for giving smaller doses means that you get fewer side effects, and bigger doses usually equal more side effects. Isn't that right? The main devices used for inhalation are DPIs and PMDIs. So DPI stands for dry powder inhaler. PMDI stands for pressurized metered dose inhalers. The main difference is that DPIs, well, they're dry and the other is wet. Think of PMDIs usually have a liquid aerosol being converted into an aerosol, a liquid being converted into a spray to deliver the drugs, kind of like your deodorant does. It's basically the medication mixed with a liquid, and then it turns into a fine mist that you then breathe in. But you need to press it and breathe in at the right time and make sure that you have enough drug taken in each time in order to meet your therapeutic needs. We call this coordination. Coordination is not a problem, however, when you're using dry powder inhaler, because you don't need to press and breathe in at specific time intervals. Instead, all DPIs are breath actuated. So the drug is delivered when you breathe in. Now, who's particularly at risk when it comes to coordination? Well, older folk, elderly people, and younger people, like small kids. They would struggle with this. Now, if only there was something we could give to help. Well, fortunately, your prayers are answered. Spacer devices can be given to help improve coordination, or to at least make it less reliant on good coordination. Spacer devices are big cylinders that hold the medication in space for a little while longer, allowing you to breathe in. In fact, they don't have to be breathing in all in one go. You could do it by breathing in and out a few times. It's just called tidal breathing. But with great power comes great responsibility. Now you must know how to keep and store your spacer devices. You must clean them once a month and not any more than that, because if you clean them too often, it can change the electrostatic charge of the device, which in turn will affect the drug delivery. Unfortunately, however, you can't use that as an excuse for cleaning your room once a month. Trust me, it doesn't work. The other advantage of using spacers is they slow the particles down so they don't get flung straight to the back of your throat. This is helpful if you are taking large doses of steroids, and steroids tend to cause candidiasis as a side effect. One of the most common spacer devices is the volumatic. It's a one-way valve and it's large, which is good because with spacer devices, the larger, the better. But unfortunately, you can't just keep giving the volumatic for every inhaler, because not all spacer devices are compatible with all inhalers. So a check must be done to see if the inhaler is compatible with a SAID or specific spacer device. Now, nebulizers Nebulizers are reserved for severe cases because they administer a much larger dose. They are in many cases driven by oxygen, especially in hospital care settings. Another reason for giving oxygen with nebulizers is because, again, we assume that we're in a serious situation here, and therefore oxygen supply to the patient is diminished. If the patient is also taking a beta-2 agonist, which they most likely will, then arterial oxygen will also be further diminished because that is one of the effects of beta-2 agonists. So therefore we tend to give the nebulizer with oxygen, and it's usually given over 5 to 10 minutes or more. Nebulizers work by converting a solution to an aerosol. That's kind of familiar. We've heard that somewhere before, haven't we? However, they do deliver a much higher and more consistent dose than your inhaler. Nebulizers are used in conditions like croup, cystic fibrosis, severe asthma, and severe COPD. So types of nebulizers include jet nebulizers, tubing, and ultrasonic. They work in basically various ways to do the same thing. Really, what is more important for you to know, however, is when to prescribe nebulizers. They're not available on the NHS in England, but VAT is not charged. So they shouldn't be just prescribed willy-nilly. Although price should never be a deciding factor, it is important to know when actually it is recommended to prescribe one. Here are a few cases. After a review of the diagnosis, after a review of the therapy, and the patient's ability to handle devices, after increased doses of inhaled therapy from a handheld inhaler with a spacer device if necessary have been tried for at least 2 weeks. If the patient remains breathless despite correctly using optimal therapy. Now moving on. Other routes for administration include the oral route. We've talked about this before briefly. This method of giving drugs generally has the most side effects because it essentially goes around the body and a lot of it is lost along the way, which means we have to give higher doses. But nonetheless, this route is still available, and examples of drugs given through this route include beta-2 agonists. I can literally just think of one example: corticosteroids, leukotrienes, and theophylline. The last route to look at is the parenteral route, which means essentially just away from the mouth. This is either subcutaneous or IV. As you can imagine, this is a very direct route. It bypasses the usual security checks and is therefore the most risky. Because of this, it is reserved for emergencies, and an example of this would be given aminophylline, which is 20 times more soluble than its oral counterpart, theophylline. The last thing we're offered in the BNF on this chapter is nice decisions for inhalers. Inhaler devices for children under the age of 5 with chronic asthma, according to NICE. When selecting inhaler devices for children under 5 with chronic asthma, a child needs and likelihood of good compliance should govern the choice of inhaler and spacer device. Only then should the price be considered. Corticosteroid and bronchodilator therapy should be delivered by pressurized metered dose inhalers and spacer device with a face mask if required. If this is not effective, then depending on the child's condition, nebulized therapy may be considered, and in children over 3 years old, a dry powder inhaler may also be considered. Inhaler devices for children between the ages of 5 to 15 with chronic asthma. When selecting inhaler devices for children between 5 and 15 with chronic asthma, again, The child's needs and ability to maintain and develop good technique and the likelihood of good compliance should govern the choice of inhaler and spacer device. Only then should cost be considered. So, corticosteroid therapy should be routinely delivered by a pressurized metered-dose inhaler and spacer device. For other inhaled drugs, particularly bronchodilators, a wide range of devices should be considered. Children and the carers need to be trained in the use of the chosen device. Suitability of the device should be reviewed at least annually. Inhaler technique and compliance should also be monitored. Thank you for listening.